the predisposing factors, the types of the bisphosphonates, classification, and the management. So, what is MRONJ? Now, to say this patient has MRONJ, we should have an exposed bone that has been present for over 8 weeks with intraoral or extraoral fistulas, while the patient is on or was on anti-resorptive medications or on anti-angiogenic medications, with no history of radiations or metastatic disease to the jaws. Now, the mandible is the more commonly affected bone with MRONJ because it has a poorer blood supply and it's more compact bone compared to the maxilla. The blood supply to the maxilla is much better than that for the mandible. So, in the mandible, it's about 75% of the cases. In the maxilla, there's 25%, and both jaws 4.5%. Now, the most common predisposing factor is dental-alveolar surgery, extraction while the patient on bisphosphonates and the dentist didn't check or the patient didn't say, and so on. So, about 62 to 82% of the cases because of previous extraction. Concomitant oral disease, a risk factor among 50% of the cases, trauma, smoking, steroids, immunocompromised, autoimmune disease, DM, and chemotherapy. So that's how it looks. An exposed palatal torus. Maybe there was procedure to it, maybe there was a trauma to it, an ulcer or whatever caused it to happen. Here we have a maxillary bone exposure. As you can see, the nasopalatine canal apparent here. Here we can see a multiple myeloma patient on the meta with recent extractions and caused this exposed bone. So that's the clinical picture, how it looks. The signs and symptoms are variable from pain to swelling to redness of the gingiva surrounding the exposed bone, pus, fistulas, pathological fractures, and so on. So here's this patient, and here's the bone of the MRONJ or the necrotic bone here on the CT scan. So as we said, the signs and symptoms include pain, swelling, redness, bad taste, non-healing extraction sockets, loose teeth, fistulas, pathological fractures, and so on. Now, there is something called the C-terminal telepeptide test, CTX. Now, this is usually seen in females premenopausal should be between 40 to 465, in females postmenopausal 104 to 1000, in males 60 to 700. Now, we can find elevated levels in osteoporosis patients, and we can find with osteopenia, Paget's disease, hyperthyroidism, and hypothyroidism. So, if the CTX is low, this means there's a high risk of MRONJ. So, the risk is high if the CTX is below 100, moderate if it's 100 to 150, low above 150 within normal limits. But is it a reliable marker? Is it something that we should always depend on it? Most of the cases, no. It gives us an indication. But it's not routinely indicated for any patient that's about to go for a surgery, for an oral surgery, let's say. So here are some articles that will tell us it's not reliable for preventive or predictive measures for such complications. Now it has different names. It can be anti-resorptive induced, it can be drug induced, it can be medication induced, it can be MRONJ, bisphosphonate induced. Now, zilindronate is the most common or the most potent and the most used one. Now, clodronate, it has a dose-dependent effects. At low doses, it can stimulate osteoblast formation. At high doses, it can work like the other bisphosphonates. Now, the problem with these medications is that their effects last a very long period of time. meaning they can remain for about 12 years, 10 years. So if the patient stopped them for about 8 years, for example, or 7 years or 6 years, it doesn't mean they're out of the risk. Now, there are two types of bisphosphonates: the nitrogen containing, which are more commonly associated with MRONJ, like zilendronate, or non-nitrogen containing, like ethydronate. Now, these bisphosphonates are used to reduce the bone turnover. They are anti-resorptive. They can be given for hypercalcemia, malignancy, spinal cord compression, pathological fractures, prevention of osteoporosis-related fractures. Orally or parenterally can be given. Now, if we have good multidisciplinary team, usually before the patient starts bisphosphonate therapy, the oncologist or the hematologist, whoever is going to prescribe it, the orthopedic surgeon, will refer the patient to you and tell you, check his teeth, make sure there are nothing needs extraction right now or something like that. So if the patient was referred to you before the initiation of bisphosphonate therapy, any teeth with questionable prognosis are extracted. Non-restorable, poor prognosis, questionable prognosis, anything that might become a problem, might need extraction in the future, no. It's recommended we allow 14 to 21 days to adequate healing, usually 2 months in American guidelines. Restorative dentistry scaling prophylaxis, they're completed before bisphosphonates, but we can do them during the bisphosphonate therapy. And examinations, routine, good oral health is very important to let the patient know, so we do not get into the problem of extraction later on. Now, usually in these cases, this tooth is indicated for extraction, but this patient is on bisphosphonate therapy, so we do not do extraction. We try our best to preserve it as much as we can with root canal treatment. Now, if the patient is on bisphosphonate therapy, now if it's IV, no surgical procedure can be done for these patients. If the patient has been taking them orally for less than 4 years with no clinical risk factors like DM, steroid therapy, medical conditions making the patient immunocompromised, no clinical changes can be needed, no alteration in the treatment is required. We can do a procedure easily without any problems, without any complications, atraumatic surgery as much as we can, and everything's going to go all right. But if it's less than 4 years with clinical risk factors, we prefer a drug holiday. Now, a drug holiday has been different in some guidelines. Now, usually, the agreed upon time is about 3 to 6 months, meaning before the procedure, we stop 2 months in the American guidelines and 2 months after the procedure. In the European and German guidelines, about 3 to 6 months before and 3 to 6 months after. Okay. Now, as for the staging, if the patient is at risk, he's on bisphosphonate, but there's no bone exposure, there's no bone, no necrotic bone apparent, vague symptoms, we do nothing. We just keep them on good oral health, good maintenance, good follow-up appointments. For stage 0, no clinical evidence of necrotic bone, non-specific clinical angiographic findings, usually pain, change in the bony trabeculae on the, say, in the OPGs. Now, for the stage 1, it's been in up to 50%. So from stage 0 to 1, it's been there for 50% of the cases has happened. So we usually clinical follow-up with conservative treatment, and we provide symptomatic treatment, pain control, manage treatable conditions, caries, periodontal disease. Any procedure with the soft tissue, it's fine, there's nothing wrong with it, but bony surgery is preferably not to be done. Now, as for stage 1, we have a clinical, exposed and necrotic bone without pus, without any symptoms. Usually we give chlorhexidine 0.12%, close monitoring. Now we don't need any surgery, just the sharp bony edges, we smooth them down. For stage 2, there is exposed and necrotic bone, symptomatic with pain and pus. Here we need antibiotic therapy, systemic antibiotic therapy with oral antimicrobial rinses. Penicillin is still effective. Quinolones, metronidazole, clindamycin, doxycycline if the patient is penicillin allergic. Now, refractory cases may require IV antibiotics. Sometimes we need to hospitalize the patients just for IV medications. In stage 3, there will be fractures, extraoral fistulas, oral-antral communication, pain, infection beyond the alveolar bone, and osteolysis to the inferior border of the mandible or maxillary sinus floor. Now here, surgical management is required. Debridement, resection with antibiotic therapy. Now, resection is reserved for extensive late presentation. If there is mobile segment, we remove them, but if it's fixed, we leave them. Care should be taken not to expose the uninvolved bone, to not extend the disease. And long-term cessation of bisphosphonate therapy may be beneficial in healing. For long-term follow-up, we need to keep the patient on regular monitoring and to prevent spontaneous fractures. Now, let's say we need to do a surgery for this patient. We must do a surgery for this patient. And he's on bisphosphonates. What can we do? What are the options that we have? We have hyperbaric oxygen therapy, which involves breathing 100% oxygen in pressurized chamber, promoting healing and reducing inflammation, but it's not a first-line therapy. It goes on the old principle, which is that the bone is hypocellular, hypoxic, and hypovascular. Low in cells, low in blood supply, and low in oxygen. So for mild to moderate cases, we can use also 2 antibiotics called pentoxifylline and tocopherol. Now here's a case that this patient had implants placed 15 years ago. The patient was treated with Zometa, and we have exposed bone, as we can see. The mobile segments and the implants were removed. Here we have MRONJ in the left side of the mandible with pathological fracture. Resection and recon plate with bone graft was placed for this patient. Now here are the references, and hopefully it's a short lecture just to guide you what to do. So basically, if the patient is on bisphosphonate therapy, we try always to preserve the teeth. If we need to do a procedure, refer the patient to an oral maxillofacial surgeon. Take consultations always. Be safe. That's the best you can do. And thank you. If you have any questions, I'm always available.